In this video, I will explain how to interpret an ECG using anatomy in atrial flutter. In typical atrial flutter, the atria fire rapidly around 300 bpm due to a reentrant circuit, usually in the right atrium around the tricuspid annulus. This creates regular, sawtooth flutter waves, best seen in leads 2, 3, and AVF, with a predictable ventricular response, often a division of 300. In contrast, atrial fibrillation shows no organized flutter waves, only chaotic, irregular baseline activity with an irregularly irregular rhythm. Atypical atrial flutter arises from different circuits, often in the left atrium, and produces irregular, non-sawtooth flutter waves, making ECG diagnosis more complex. Typical atrial flutter involves a macro-reentrant circuit in the right atrium, circulating counterclockwise around the tricuspid valve. The wavefront travels down the right atrial free wall, through the covered tricuspid isthmus, and up the septum, completing the loop and producing rapid, regular atrial depolarizations. Right atrial flutter is typically counterclockwise around the tricuspid valve, which is called typical flutter, and shows sawtooth waves in leads 2, 3, and AVF. Clockwise right atrial flutter is less common and inverts this pattern. Left atrial flutter originates from circuits around structures like the mitral annulus or prior ablation scours and produces atypical, irregular flutter waves, often without the classic sawtooth. ECG clues include non-sawtooth morphology, variable P-wave axes, and unusual lead patterns, especially in V1. Catheter ablation for atrial flutter targets the covered tricuspid isthmus in the right atrium, which is the critical part of the reentrant circuit in typical flutter. It's a highly effective, first-line treatment, with success rates over 90% and a low complication risk. It's done via femoral vein access, using radio frequency or pulsed field energy to create a line of block, preventing recurrence of the flutter circuit.